A very good afternoon, everyone. It is with great honor and pleasure to welcome you all to this 25th Pediatric TB Eco Clinic in collaboration with Regional Pediatric Center of Excellence for Tuberculosis. The Eco Clinic is a dynamic platform for case-based clinical discussions and dissemination of knowledge and bringing all experts together across the country for managing tuberculosis among children. On behalf of National Institute of Tuberculosis and Respiratory Diseases, that is NITRD, I extend a very warm welcome to our esteemed Deputy Director General TB, Central TB Division, Dr. Shubhni Rajan, and her team. I also extend my heartfelt welcome to Dr. Sanjay Kumar Mattu, Joint Commissioner and Additional DDG, Central TB Division, Dr. Neelam Mohan, IAP President 2026, Dr. M. Singaravelu, President-elect IAP 2026, the directors and representatives from NIRT, NTI, State TB officers, directors of STDCs, esteemed faculty members from various medical colleges across the country, district TB officers, medical officers, pediatric TB specialists, and all healthcare professionals participating in today's session. Now, please let me introduce the faculty from NITRD. I am Dr. Dhulika Dhingra, Specialist Peds at NITRD, and I will be moderating today's session. And with me is Dr. Sangeeta Sharma, Chief in charge of the National Center of Excellence for Pediatric TB and also former director of NITRD. To my extreme right is Dr. Alok Yadav, CMO, NFSG, and pediatrician at NITRD. Dr. Upasana Agarwal, ma'am, is busy in a meeting. She won't be able to join for today's session. I would now request Dr. Sangeeta Sharma, ma'am, to please address the gathering and also welcome our esteemed dignitaries. Over to you, ma'am.
Thank you, Dr. Dhulika, for your kind words starting the ball rolling. So we are very lucky that this session we are joined by none other than President of Indian Academy of Pediatrics, that is Professor Dr. Neelam Mohan. We pediatricians, we are lucky to have her because she is a role model for all of us. And also the President-elect 2026, that is Dr. Singaravelu, is also there with us. So the commitment of the leaders at Central IAP, that is the President and President-elect, it shows the commitment the Indian Academy of Pediatrics offers us as a pediatric team. Also, we have our head of the National TB Elimination Program, that is the DDG TB, Dr. Shobhani Rajan, and the Joint Commissioner, that ADG, Dr. Sanjay Mattu. As you are all aware, we have been conducting these monthly sessions in which we discuss interesting cases which leave a lesson to be learned and add on to our knowledge. Because it's a learning platform and we are here to interact with each other and carry this stream forward, And now I'll request our president, that is Dr. Neelam Mohan, to say a few words. Dr. Neelam.
Thank you so much. It's indeed a pleasure to be on this forum for tuberculosis. As we all know, there is a national tuberculosis elimination program, and it is the responsibility of all the pediatricians and, of course, the leadership to take this head on with us. I was looking at the statistics which are saying that probably a lot of pediatric tuberculosis in India is going unrecognized. I would request the experts also to comment on this because IAP has collaborated with an organization, Sarthi, which is being also working with government. And that is how I thought 1:1 will become level. And the data is saying based on the global data, the incidence of tuberculosis in is not there. Many of them are going unrecognized. And what needs to be done on this is also extremely important to understand because any message that is given can give rise to two extremes. It can end up with overdiagnosis too. So I would be requesting the experts, and Sangeeta is doing a good job in these cases. And we all know her past experience as director in these institutes, and there are experts like Varinder, etc., who are also doing. And I was also connected by the National TB Elimination Program, and also I also got in touch with the WHO team trying to understand this. So I would request the experts to highlight me before they venture is what the truth about status of pediatric tuberculosis in India. Is that report right? And what's your insight? Thank you so much for having me over, and it's indeed a pleasure to see Dr. Sindhu, who, as you rightly said, the commitment that comes in both of us have been very academic, and I'm really proud that both of us are making things 1+1 to by the 11, and I'm truly proud with all the support that we have with each other. Thank you. So this report was saying that. Suspect the one in TB cases is supposed to occur in India and it is getting undiagnosed. So I'm looking for your comments, Sandeep.
Thank you so much. Actually, what you've highlighted, that is one of the major concerns of the country. As per the pediatric global caseload, 1.3 million are in children out of the 10.7. Reported by the WHO Global TB Report 2025, because 2026 will be there somewhere in October. So, coming to specifically for children, out of this 1.3 million, it is estimated that almost 31% are from India for children. And that makes the data for us somewhere between 11 to 12% of the caseload in India is children. So we had 28 lakh cases detected in our country. The case notification for pediatrics has been improving over the years, and the reasons are that these platforms to spread awareness among pediatricians. That is, I would say, that is because you need to, the eye would see whatever you know. So we need to spread awareness amongst our pediatricians so that more and more children are detected. As regards the program is offering free diagnostics, and these diagnostics as Gene Expert and in the future Expert Ultra, including samples which are respiratory, and we are in the process of adopting stool also, which is a non-respiratory sample. The case detection has definitely gone up, but still the case detection gap remains. The thing remember is that all the diagnostics and the drugs, they're available freely under the program, and the government is also offering the incentive, that is the direct bank transfer, and also helping the patients with the Nikshay Mitras. That is, anyone can come forward to help the patient for either the treatment part, or even the vocational part, to get the child or the patient to the center. So all these facilities, they've been the program has been working very hard, and now we have specific for diagnostics. We have universal DST, that is our crosses to diagnose with the microbiological tests available, because the regimens which are available, they are dependent upon the DST, and the most important drug is rifampicin. So we have different regimens available, that is rifampicin sensitive, then IMH resistant, then rifampicin resistance, or the MDR or pre-XDR regimens. So Dr. Neelam, the program is working very hard, but we all need to stand together and we all need to work together. And that is the reason precisely you are also a source of encouragement to us. Your mere presence and you sparing your valuable time logging with us is a source of encouragement to the pediatricians who have joined. So thank you once again, and I think I'm able to answer your question. Thank you.
Thank you so much. And I would just say, I don't want to disturb the whole thing, but I was preparing some module for air pollution. It's a very small, 3 minutes module, how to empower people on pollution. And I think there is a time when we can create something extremely small because the attention power of pediatricians is not very high. And we will sit along with, I mean, you can have the eco team and your experts. We should prepare very short 10 questions which are meant for the pediatricians to question this. I'll prepare that and we'll get in touch. And I hope we are able to do something in that contest because this is what I was approached about, that though it is 1 in 10, but in India it's not happening and how you can help us. Thank you so much for giving this opportunity. I look forward to working together for National TB Elimination. Best wishes.
Thank you so much, Dr. Neelam, and thank you for your best wishes. And we'll surely be, more than happy to offer anything which is of help to the Indian Academy of Pediatrics. So over to Dr. Dhulika now.
Thank you, ma'am, for sharing your time and expertise with us. Your guidance and wisdom has given us much to reflect upon and learn from. I would now request Dr. M. Singaravelu to please speak a few words and address the gathering.
Thank you, Doctor. Thank you, Dr. Sangeet Sharma, and our President Neelam Agam, and all the dignitaries, Dr. Kamal, and all others who are in the platform. As our President rightly said, as I really appreciate Sangeeta Sharma Madam's commitment for continuously. She is working hard when she was in as a director, even after also that her continue commitment for elimination of TB and also dissipating the knowledge to our pediatrician and postgraduates through this webinar also is really laudable. But here I am very happy that our President Neelamahan is here. Surely, ma'am, definitely your vision should be taken because though the government is doing a lot, surely the stage has come from overdiagnosis of tuberculosis. I can say 15 years back, where everybody used to write whenever any child comes with a cough which is not controlled, moment they see, take one X-ray, see some haziness, start ATT. Now the stage has gone to underdiagnosis because we think that people we have eliminated tuberculosis, which is not the real scenario. But as our president told, we are already through IMA and all that few years back, we are strongly propagated to all the along with the government. But somewhat our IAP also took that initiative few years back, but it was not fully materialized. But now our dynamic visionary president is there. And the next year I am there. We both can, with Shankita Sharma ma'am initiative, we can, through government, we can go together and we can try to sensitize in a better way to the practicing pediatrician to others. Because when I was a dean, I brought the JCB net. It was a big luxury ware which was not there anywhere near 3-4 districts. It was not available. Now it has things has improved, but still we are lacking in diagnosis because whatever we get our resistant cases are increasing. Surely, madam, if we are very fortunate with our Neelam and myself, with all your inputs, definitely we will try to take in a bigger way to dissipate the knowledge so that we can be in the part of national tuberculosis elimination. With this, I really congratulate your consistent efforts in disseminating the knowledge and bringing rare cases so that people will get more sensitization. With this, I wish you all a happy learning. Sure that, Madam Neelam, my sincere request, this should every third week Madam is doing, I mean, this particular day, we have to incorporate with our activity also, and we can, through all IAP, we can spread the message so people can be benefited. From my side, I am also putting request to our president. Over to you, ma'am. Thank you.
That's very kind. Thank you so much and well done. But I was just invited a couple of minutes back to join, so I didn't have the message before. So it is a reflection to darling Sangeeta to inform me beforehand the case and the link before so that I can share it with the others. Thank you so much.
Yeah, I think we'll take care, because uh, I think this time we are a bit delayed because even we'll be seeing the case for the first time. So sorry for the apologies, all blame on us. And from next time, we'll make it certain that the case reaches us at least a week prior. So, Dr. Tulik.
Yeah, thank you, sir. I would now request Dr. Sangeeta Sharma to please welcome Dr. Shobhini Rajan.
Yeah, Dr. Shobhini is the head of our National TB Elimination Program. She was in charge, she still is in charge of the NACO, and so she's carrying the dual band forward. Dr. Shobhini, your words of wisdom, please.
Thank you, Dr. Sangeeta. I just want to say that I am no longer with NACO. I'm full-fledged with Central TB Division.
I'm sorry.
And
I
thank you for inviting me here. And it was really heartening to hear the engagement of Indian Academy of Pediatrics, IAP, in terms of the top leadership, indicating commitment to work closely with the TB elimination efforts under the government. So, the difficult to treat clinic that NITRD is taking forward, especially for the pediatrics populations, is really a very good initiative. In this, we are doing a dual job, one of presenting these cases to a discerning audience of pediatricians, where we can basically dissect what we have learned and improve our knowledge base. And the second gain that we have is that we also invite all our district TB officers and our medical officers from the periphery. So it gives them a chance to understand a specialty approach to managing TB. So the difficult to treat TB clinic we were having for the adult population, which celebrated the 100th day recently, and in the pediatrics group also, I'm very confident that NITRD and Dr. Sangeeta in particular will be taking this initiative forward with these interesting cases every month. And please be assured of all support from Central TB Division and my colleagues at CTD towards making this a resounding success. We'll make sure that all our field functionaries also continue to participate. So thank you, and in the interest of time, I'm handing back to you to take it forward.
Thank you so much, ma'am. Your thoughtful words and rich experience have greatly enriched this gathering. I will request the audience to please attempt the pre-test questionnaire, the link for which has already been shared in the chat box. So now, without any further delay, we would like to start today's session. Today's presenting team is Department of Pediatrics, Kalavati Saran Children's Hospital and Associated Lady Harding Medical College, led by Dr. Kamal Kumar Singhal. He's the professor in Department of Pediatrics at Kalavati Saran Children's Hospital. The case will be presented by Dr. Shilpi Chauhan, senior resident, and Dr. Soumya, who is a postgraduate resident in the Department of Pediatrics, Kalavati Saran Children's Hospital. So over to the team. You can start sharing your screen so that your case is shared.
Ma'am, may I start?
Yes, please.
A very good afternoon to all respected teachers, seniors and colleagues. Today we, the Department of Pediatrics, Lady Harding Medical College and Kalavati Saran Children's Hospital will be presenting before you a case of presumptive MDR TB, which posed as a diagnostic challenge before us. Myself, Dr. Soumya, and I will be presenting the case along with Dr. Shilpi, Senior Resident LHMC, and the presentation is moderated by Dr. Kamal Sir, Professor Pediatrics at LHMC.
1 minute. 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 1 minute.
We are presenting the case of a 7-month-old male infant, resident of Faridabad, Haryana, who presented to us on 26th of June last year and stayed with us for a long duration of 76 days and was discharged finally on the 11th of September 2025. At the time of presentation, the child had the following presenting complaints: fever for 1 month, cough with cold for 2 weeks, fast breathing for the past 7 days, and loose stools for the past 4 days. Fever was undocumented, relieved on medication, off and on, not associated with any chills or rigor, not associated with any rash, with reduced appetite and inadequate weight gain. There was also a cough, which was non-spasmodic, non-paroxysmal, dry, associated with coryza. There was partial relief from home nebulizations. There wasn't any history of foreign body inhalation. The child had been experiencing fast breathing for the past 7 days. Also, there were loose stools for the past 4 days, which were almost 5 to 6 episodes per day, watery, yellowish, non-mucoid, and non-blood-stained. There was no history of any irritability or lethargy, no history of any vomiting or feed intolerance. There was no history of difficulty in passing stool or visible bowel movements. There was no history of any neck swelling or swelling in axillary or inguinal region. History of hospitalization for age for.
So, Dr. Soumya,
Yes.
just hold on. I think there has been a lot of information in this, so we will hold back at the end of history and we'll look at all the questions that there are, because we have gone through that very busy slide. There's a lot of information. So if you have any doubts, any clarification that you wish to seek, as Shifa has written there, put your questions, and we will continue with history. At the end of our summary, we will halt. We will look at all the clarifications that anybody wants to have. Yes, Dr. Soumya, please continue. Sorry for interruption.
Yes, sir. So this is the slide displaying the history of present illness. There was a past history of hospitalization in view of AG with severe dehydration at another health facility, which happened almost 1 month back. And that time the child was hospitalized for 7 days. During this course, the child received IV fluids and IV antibiotics. However, details of the same are not available with us. The mother was a known case of pulmonary TB, and she had been diagnosed 2 years prior, and she had received ATT for 6 months. That was 1 complete year before the birth of the child, and the mother was currently doing well. The child was mostly milk fed by undiluted cow's milk and was predominantly fed via milk bottle. The child was immunized only at birth and the BCG mark were present. Rest, antenatal, birth, and developmental history were normal. So to summarize, we have before us a 7-month-old male child who was developmentally normal, inadequately immunized for age, second born to a non-consanguineous marriage, belonging to the lower middle socioeconomic class, who presented to us with complaint of fever and no weight gain for 1 month, dry cough for 2 weeks, fast breathing for 7 days, and loose stools for 4 days with poor feeding. There had been a similar episode of loose stools that happened 1 month ago. The mother was a known case of pulmonary TB 2 years ago, had completed 6 months of ATT, currently was asymptomatic. The child was bottle fed with undiluted cow's milk.
So thank you, Dr. Soumya. I think it's up to Dr. Dhulika ma'am. Would you want to ask some questions, or should we ask it in the end of examination itself?
What was the status of the mother's sputum? Was she DSTB, sensitive TB? Was she drug-resistant TB?
Ma'am, drug sensitive TB.
So you had all the papers proven?
Yes, ma'am. Yes, ma'am. She had her TB card with us, the ATT card with us.
So she was sputum positive at the beginning, and then sputum status was not known at the end of the treatment.
Yes, ma'am. The sputum state was not known at the end of the treatment.
Okay,
But I think she
positive in the beginning.
Yes, ma'am. She was positive by sputum at the beginning.
And the chest X-ray showed improvement.
Ma'am,
we did not have the radiograph
with us.
What we know is that she responded well, and within 6 months the treatment was stopped, and thereafter the mother is currently well.
Because this is very important, if you have the mother who has history of pulmonary tuberculosis and there's a small infant in the house, so you need to know the sputum status at the end of the treatment for the mother.
Yes, ma'am.
So, Soumya, would you want to comment on this? She was treated 2 years back. The child is 7 months.
Sir, the mother had taken ADT, but once her medication were completed for 6 months, there was not any repeat sputum examination that was done or any repeat
So the child
radiograph.
was not born till then.
Yes.
Another
The child is currently 7 months old child. The treatment she took was 2 years back.
For pediatricians, we need to understand that all these things are very important to because the history of contact, especially if it was a sputum positive pulmonary tuberculosis case, and we also need to know the sputum status at present because the child is developing some symptoms which may turn out to be tuberculosis because the child has got fever, no weight gain, fast breathing, and even cough for more than 2 weeks. So, in such a scenario, we need to re-examine the mother, get her chest X-ray done, and also get her sputum status done, and even others in the family. They also need to be screened.
Yes, ma'am.
So that will be presenting that data, ma'am. The contact surveys, that is a part of management. They will be presenting that.
This is for the information of the house. So as we are proceeding, step by step. So this is important right now.
Yes, ma'am.
Yes.
Good afternoon, ma'am. This is Dr. Indranath Roy, microbiologist from IRL, Kolkata. So as per NTP, the outcome of mother must be either completed or cured. So it is mentioned it is completed. That means the microscopy at the end of the course, that means after the 6 months has not been done or it is not reported on the NICSHOI. So on this information, not cured.
This is what precisely I was asking them, that what is written on the treatment card of the mother, that whether she was treatment completed or whether she was cured. So cure we label if initially of a sputum positive patient, the status at the end of the treatment is sputum negative. But if in case the sputum cannot be done at the end of the treatment, then the outcome is declared as cured. Treatment completed. So over here it is completed. They are saying that the status of the mother at the end of treatment was not known.
Yes. Thank you.
Dr. Soumya, please carry on.
Yes, ma'am. So to depict before you the examination findings at presentation, the child was 5 kg in weight and had a length of 65 centimeters. Evaluating the following parameter, we found that the child was severely underweight and had a weightful length that stands at minus 3.57 standard deviation and hence was severely acutely malnourished with an MUAC of 9 centimeters. The child was tachypnic at presentation with a respiratory rate of 80 per minute and heart rate of 130 per minute. The child had subcostal retractions and intercostal retractions. However, no nasal flaring were present. The saturation on room air was 94%. And the child was maintaining a temperature of 98.8 degree Fahrenheit at presentation. The peripheries were warm. The pulse volume was good and all peripheral pulses were palpable.
I would appreciate if you can just tell them about the respiratory rate related to age because they are not all pediatricians. Because that would be of help to them.
Yes, good idea. Soumya, please tell what are the cutoffs for the different age when you call it fast breathing in children?
Sir, basically it is different and dependent on the different ages. So in newborn, in neonates, a respiratory rate of more than 60 would be considered as
less than 2 months of age. It is 60.
60.
Cutoff is 60. Till
Then,
12 months,
it is 50, and after that, more than 40 would be considered as tachypnea.
So if you count, so it is for the DTOs that if you count the respiratory rate of the child, that itself gives you a clue that the child has a significant respiratory illness. Significant means which needs some kind, otherwise it is not fast breathing. So less than 2 months of age, anything beyond 60 per minute, 2 months to 12 months of age, anything beyond 50 per minute, and 12 months to almost 5 years of age, anything beyond 40 per minute is called fast breathing, and that is where we need to act. And a rate less than that is only cough, cold, no pneumonia.
So now these have been included under the program as 10 symptom screening. Under NTP, we have included this 10 symptom screening for tuberculosis, and that includes the respiratory rate also. Continue, please.
Yes, ma'am. On general physical examination, the child had sparse, lightly pigmented hair with sunken eyes and delayed skin pinch. Also, pallor was noticed. Rest all general physical examination was normal. On examining the respiratory system, on inspecting, we found the child to be tachypneic. Subcostal intercostal retractions were present. There was reduced chest movement on the right side. However, no deformity or grunting was noticed. On palpation, the chest was warm to touch, no tenderness, trachea was central. There was reduced tactile fremitus on the right side, especially in the interscapular and infrascapular region. The percussion was dull in the right side interscapular and infrascapular region, and there was reduced air entry and crackles on auscultation in the right interscapular and infrascapular region, and bilateral wheeze was also present. Rest all systemic examination was within normal limit. So to summarize, we have before us a 7-month-old male infant, antenatal and birth history uneventful, developmentally normal for age, inadequately immunized for age, on faulty feeding practices, that is bottle feed with undiluted cow's milk. The second born of a non-consanguineous marriage belonging to lower middle socioeconomic class, who presented to us with complaint of fever and no weight gain for 1 month, cough for 2 weeks, and fast breathing for 7 days, and loose stools for 4 days with poor feeding. The child had a similar episode of loose stools 1 month ago. The mother was a known case of pulmonary TB detected 2 years earlier, who had completed 6 months of ATD and was currently asymptomatic. The child was underweight and severely acutely malnourished. Was dehydrated at presentation with sunken eyes and dry oral mucosa, pallor present with right-sided lower respiratory involvement, likely collapse consolidation, and rest other systemic examination within normal limit. The following possibilities were what was considered by the treating unit. That the child is a case of severe acute malnutrition with complications, that is pneumonia or diarrhea. The first differential to be considered was pulmonary tuberculosis in the light of the mother being a known case of pulmonary TB. The second diagnosis was immunodeficiency secondary to HIV. Also, a differential of primary immunodeficiency syndrome was considered. At the time of admission, the child had a hemoglobin of 10.5 and a TLC count of 12,000. Also, the other significant investigation finding was that the CRP was 20, and the X-ray findings, as can be seen, was that the right upper zone showed airspace opacities. The chest film showed bilateral hyperinflation with slight mediastinal shift towards the right, and there were also right paracardiac infiltrates that were present. At the time of admission itself, the child was tested for gastric aspirate, in which CBNAT came out to be negative for MTB. However, since the clinical suspicion for TB was high, the child was prepared for a CCT test. As we can see in the CCT test that was taken during the course of the hospital stay of the child, there was narrowing in the right main bronchus and the right intermediate bronchus. Also, at various levels in the CT, we could see necrotic lymph nodes. As depicted in the picture, there was right hilar lymph node that was necrotic. Also, we could visualize the pretracheal necrotic lymph node, the paratracheal necrotic lymph node, and the subcarinal nephrotic lymph node. The CT also revealed right side collapse consolidation with non-specific ground glass opacities. Initially, the child was started on IV antibiotics, O2 by nasal prongs, and on supportive management for diarrhea, and dehydration was corrected. The JCBNAT was negative, but following the CT report that showed necrotic lymph nodes, ATT on radiological session with steroids. Subsequently, a bronchoscopy was also planned. The bronchoscopic findings revealed carinal widening and right intermedius bronchus narrowing with extra luminous compression compromising the lumen of the right intermediate bronchus by 70 to 80%. There's also distortion of the right middle lobe and the right lower lobe. The remainder of the airway was normal. The bronchoalveolar lavage that was taken from the procedure was sent for testing, which revealed a cytological report of 1130 cells, with 78% of them being mononuclear. The BAL CBNAT was positive with MTB detected that was rifampicin sensitive. The diagnosis was then changed to microbiologically confirmed TB, and ATT with steroid were continued. At the time of admission, as we can see that the child had a history of cough with fever and loose stools, was tachypneic and with subcostal and intercostal retractions present. The child was initially managed on O2 by nasal prongs and antibiotics. This was the X-ray of the child that was depicted at presentation. At this
Soumya,
time,
use a pointer if you can, because it was better to animate, but use a pointer if so that people know where we are. So we are on the left side.
The
slide
first
set
column
first.
on the
Yes.
left side. After almost 1 month of stay, after almost 3 weeks of being started on ATT plus steroid, the child showed improvement in the constitutional symptoms. That is, fever had improved, loose stools had resolved, and cough and respiratory distress had was still persisting. The respiratory rate was still 68 per minute with retractions that was still persisting. At this time, the child's O2 support had been escalated, and the child was currently on H3 support even after 3 weeks of ATT plus steroids and antibiotics. As we can see on the X-ray that there were persisting opacities that were seen, and also there was increasing respiratory distress and a requirement of H3 that was continuing despite the child being on ATT plus steroid for almost 6 weeks.
So I think this slide was animated. I don't know how it went off, but yes, the idea is that after almost 2 months of anti-tubercular therapy, the child is the fever is improved, the acute conditions like the loose stools and all everything resolved, but the distress kept on increasing. The radiological shadow persisted, and the child continued to require high flow oxygen. He was on HFNC, so it was he was not even maintaining on oxygen by nasal catheter or a mask also. So he required increased support despite 2 months of anti-tubercular therapy in a child where the fever has come down, it's not there. The loose stools has come down. The distress has marked, the constitutional symptoms otherwise are better. Yes, Dr. Soumya.
Yes, sir. So at this point,
so this I think is the most important slide of this presentation, because if there are any questions that have to come, this is what the thought process should be at this point of time, because this onwards we will start unfolding the diagnosis probably. So this is the point where if there are any questions, are there any comments, we can take up that. There is one comment in the chat box. If madam you permit me, should I answer that? The vocal fremitus in 7-month-old child. Professor Sood has asked that.
Yes, sure.
So, we do vocal fremitus even in infants, just that the technique is different. The way we do in adults. In adults, we compare the intercostal spaces with left and right. But in pediatrics, because the chest cage is small, we use a different technique. Some people would say, so if you look at macleoids and different books, they would say the intercostal spaces are too small to compare. So we compare areas. For example, the right memory with the left memory. For that, you can use the palm of the hand, and even the fingers can be used to compare left and right. So this is the method that we use in infants, which is there, and it all depends on how whether which technique you have practiced, and we are able to get good information. So intervertebral spaces, interscapular spaces, memory, inframemory, we are able to compare that. The last slide, I think we just shown that the fever gone, the appetite good, the weight gain present, and the loose stool resolved, but the distress is worsening there, and the need for support is increasing. So this is probably the gist of this slide.
I think
so. Shall we proceed, Dr. Dhulika?
Yes, absolutely.
Dr. Soumya,
Yes,
you can
sir.
proceed.
So at this point, we were faced with a diagnostic dilemma since the child had shown resolution of the constitutional symptoms. However, the respiratory distress was not just persisting but worsening. The following possibilities were considered in view of persistent distress in a child who had already received ATT for 6 weeks. The first was regimen dose and compliance. Given the fact that ATT is being given but is not being absorbed, probably due to intolerance, for example, if the child vomits out the drug, or due to poor compliance or adherence to a treatment regimen, it can result in persistence of symptoms despite the perceived fact that the child was on ATT. The second possibility that was considered was superadded infection. That is any bacterial or fungal infection atop of the existing tuberculosis or any infection acquired during stay. That can delay improvement in a child who has already been started on ATT. The third diagnosis that was considered was alternative diagnosis other than TB. Since the child had persistent wheeze, an airway disorder could also have been considered. The fourth condition that was considered was paradoxical reaction, that is iris-like, which actually is worsening of RD after initial improvement phase that occurs at 2 to 6 weeks after initiation of ATT, sorry. And finally, MDR-TB, in which there is no response to first-line ATT, or a secondary MDR-TB that was acquired during the course of treatment is also considered. During this time, the treating team tried to address each of these possibilities. Since the child was already an inpatient, in-house patient who was receiving ATT from the Roth Center and being administered the ATT under supervision without any reported instances of intolerance, the first possibility was ruled out. Considering that there could have been any superadded infection, the child various cultures were sent in which the bowel showed growth of Candida tropicalis and urine also showed the growth of budding yeast cell. The child had received antifungals. However, there was no improvement in respiratory distress despite the addition of antifungals and broad spectrum antibiotics. Considering that there was no period in which there was any improvement from the time of presentation, but rather there was progressive worsening, the child was not considered under the lines of paradoxical reaction. Also, a repeat bowel sample was sent in which
the
again
slides are not moving, Soumya. Okay.
Also, considering that the repeat bowel sample that was sent was again CBNAT positive with rifampicin sensitivity, the possibility of MDR-TB was also removed. Immunodeficiency workup that had been sent was also normal. The HIV was also non-reactive. Immunoglobulin levels or lymphocyte subsets and analysis and whole exome were also within normal limit. Other investigations done by the treating team was thyroid function test that was normal, B12 levels that came out to be decreased at 162 picograms per ml, a serum folate level of 18.9 nanograms per ml, stool and blood samples, culture sensitivity were within normal limits. So hence a second bronchoscopy had been planned for this child.
Excuse me, can I just ask you one question? Because the child was on steroids. Did you do any blood sugar testing?
Yes, ma'am. The child was in hospital, and all the sugar records during this period were within normal limits.
So
Because
in
that
SAM
is-
children, in
yeah.
SAM children, otherwise also it's a protocol, ma'am. During 6 state, it is monitored, and later on, depending on the need, we do monitor.
So this is another important thing. I think you can tell the house about the protocol which we follow for SAM regarding the blood sugar, etc. Because the house needs to know. We have STOs, DTOs.
So as far as in this particular child is concerned, whenever we have a severely acute malnourished child, now because they do not have body reserves, significant body reserves, so they are very liable to these hypoglycemia. So whenever they come in that acute state, we usually monitor blood sugar twice a day. That is irrespective of steroids. Now, steroids in acute short-term period, we do not see causing significant trouble. Yes, but in somebody who is on long-term steroids, like those who are interstitial lung disease or somebody who has had prolonged steroids, then we start monitoring HbA1c also, but not in this early state. That is usually after 3 months of steroids, we look at HbA1c also. But in this particular state, in the acute state, even BD, thereafter once a day, and after 7-8 days, we usually, depending on the need, we do it. Otherwise, we don't.
This is important, from the tuberculosis point of view regarding the comorbidities, SAM, and to rule out HIV, diabetes. So these things they need to be taken care of because they could be the reason of non-improvement. And the other thing is you gave antifungal. So what was the status of the urine? Obviously, you would not have repeated the ball, but regarding the status of the budding yeast cells after antifungal, they were still there or it showed improvement? Because
Ma'am, the
urinary
urine.
infections.
Yes, ma'am. The urine was sterile after 14 days of antibiotics, of antifungals, sorry.
Okay, you can proceed, Dr. Soumya.
Okay, ma'am. So considering the fact that we had ruled out all other possibilities for persistent RD in this child, a repeat bronchoscopy had been planned. The second bronchoscopy found the supraglottic structures to be normal. The carinal angle continued to be widened. The right intermediate bronchus on the lower part on the right side showed extraluminal compression medially. And this time the caseous material was occluding almost 90 to 100% of the lumen, as can be seen in the picture. During this procedure, the granulation tissue was removed using a cryophobe. This is a picture in order to depict how the granulation tissue had been occluding the right intermediate bronchus lumen prior to the bronchoscopy. And this is the pictures on the lower end are depicting the lumen once the granulation tissue had been removed by the cryophobe. We can see that the lumen had now been patent post the bronchoscopy. After the granulation removal via cryophobe during the bronchoscopy, the respiratory distress showed marked improvement, and the child was off HFNC support within 48 hours. At the time of discharge, the child had fever that was resolved and respiratory distress that was resolved. The child was discharged on very low flow oxygen at home, which was 0.5 to 1 liters per minute. And this was the chest X-ray at the time of discharge. During follow-up, after almost 2 months, the child was off O2 requirement even at home, was maintaining saturation on room air, fever and respiratory distress resolve, had gained almost 1.1 kilo weight in the past 2 months. And this was the chest X-ray that was present at the time of almost 4 months of ATT completion and 2 months after discharge. We can see the picture of the child that was taken during follow-up with the consent of the parents. The child is off O2 support. The contact survey of the rest of the cohabitating family was done, and the elder sister, who was 3 years old, had been started on INH prophylaxis. So the final diagnosis stands at severe acute malnourishment with viral pneumonia, with acute gastroenteritis with dehydration, and drug-sensitive endobronchial pulmonary tuberculosis.
So I think let's halt here. Ma'am, we had a small vignette also, but if you allow, we will present. Otherwise, this is the case that we planned.
I think we can discuss on this only.
Okay, perfect.
We have multiple points where what
Yes.
discuss.
So we will leave it here. This next vignette we will leave in the interest of time.
Yes.
Dr. Shilpi, you can start your presentation. So it's still that time, there are some questions. The chat box management of SAM URID is not standard. So I think this was with the treating unit at that time, the child who was not responding and the child who the distress was increasing. So if you have a child who has been with you for 1.5 months, who is severely acute malnourished, who has been on different kind of antibiotics, so fungal also come into play at that time. Now, had this child been well, I would say probably it was a contaminant, or we could have ignored that. But I think the treating team thought the overall scenario and chose to use antifungal. Otherwise, I agree with you. We do not have very good definitive reasons to say that it is antifungal is required. But I think sick child, SAM, prolonged antibiotics, this is a setting where fungals can create problem.
The child was on steroids and you had the fungus in the bowel. So I think giving antifungals was not a bad idea. It should have been given.
Yes. So we had to make an error. The treating team made an error, if at all it was an error, by giving rather than by not giving. You know, it's a tricky situation in a 7-month-old child.
Because the child was not improving. So you need to try all your, and there is a fungus which is growing from the bowel sample. Had it been from the gastric aspirate, I would have said, chalo chhod do. Yes, in an older child from the sputum. But from the bowel, on steroids, it's best to give. Any other question?
There is one question from STDC West Bengal. If you have remember, yes, we see, you know, the label was put before bronchoscopy was done. So in these investigations, sometimes come here and there, but the point was a clinical discussion that if a child is not responding on 1.5 to 2 months of anti-tubercular therapy, so that's where the thought of presumptive TB comes in. But yes, you are very right. If you have a rifampicin which is sensitive, then it's not technically MDR is not the right way. Presumptive MDR is not the right way to look at. It could be INH monoresistance or anything else.
So I have a question, Dr. Kamal, regarding why we plan for the repeat bronchoscopy. Actually, you had started the ATT with steroid in this child. So the only reason is that the respiratory distress child is not improving. This is the only reason, or any other reason why we plan?
So I think it's a very good question. When would you subject a child to an invasive investigation like bronchoscopy? A child has already had a bronchoscopy which shows compromised airways at some point of time. But from that time onwards, the distress kept on increasing. Now, an important clue came from examination, where if you look closely in that particular right memory region, not just the vocal fremitus was raised, not just dullness was there, the air entry was also reduced. So now when you have an air entry reduced in a child where you have dullness in that area, vocal, that indicates that there is something wrong with the lumen itself. So we see this in foreign bodies of the airway, where you have a collapse or a consolidation distal to that, but the air entry to that area is also reduced. In this particular area, if suppose the air entry was not that reduced, usually if it is consolidation alone, you will see a vocal fremitus which is very, very loud. But here, the decreased air entry made us think that probably there is some luminal compromise also. And so we went on to evaluate that.
Hello, can I make a comment? Can I be allowed to make a comment?
Yes.
Sure. Okay. So there are 2-3 points here. The mother was a treated case of the TB1 and she was given treatment. Now, whether she had the reactivation of the TB or not, one, if she had a reactivation, then child can get the disease from that. Number 2, whether there was another member of the family who got infection from the mother, and then the child was infected from that member too. And if there was no one in the family who was suffering, then there may be say, some contact. So we should be going for the reverse contact testing in this type of the cases. Okay. Then as far as presentation is concerned, once the presentation on the X-ray and on the CT was showing the narrowing, then on the clinical presentation, there can be localized bronchus. And here, the possibility of the right middle syndrome has to be kept since the intermediate bronchus was more or less 70-80% occluded. Then in case, such like case, what is the possibility is, beside the right middle lobe syndrome, the glands were there, they were necrosed, so they had fungated into the bronchus. Okay, and that was causing the narrowing, distress, and the persistence of the shadows. So the endobronchial tuberculosis can be because of the cicatrization, narrowing of the bronchus, and that can be treated well with the dilatation, balloon dilatation only. But here in this case, it was the right approach, that since the granulation tissue had invaded into the lumen of this bronchus, so the cryobiopsy was the right approach. So since the presentation on the CT and the X-rays were very much there from the very beginning, so instead of allowing this the growth to say cause more of the complications, we could have gone for the early bronchoscopy. What about this finding on the early bronchoscopy? Whether there was the narrowing of the intermediate bronchus seen, whether there was the granulation tissue seen in the early bronchoscopy, or just because the child was not responding, that you had gone for the second bronchoscopy.
Thank you, sir. Thank you for the question. I think when the first bronchoscopy was done, we only had extraluminal compression of the airway. We did not see anything fungating into the airway. So at that time, there was no way we could have tried that. So it is only in second scopy we see that the caesium has ruptured, the lymph node has ruptured into the airway and now causing intraluminal compression. In the first bronchoscopy, it did not look like a stenosis, fibrosis kind of a thing. It was a compression, extraluminal mass pressing onto the airway.
So on the first bronchoscopy, there was just a compression.
Yes,
and
extraluminal.
Despite of the adequate treatment, if the child is having the deterioration in the clinical presentation, but otherwise the fever is improving, and now the granulation tissue is coming up. So whether we should be thinking of the complication of the middle lobe syndrome only, or we should also be thinking about the drug resistance in this type of the child, and that is a issue. So on second bronchoscopy, once we were removing the granulation tissue, whether that was subjected to the NARTSET testing, the culture, and whether there is the results are there, known or not. Since child was also given the steroids, so in such like scenario, with steroid, there can be the regression of the glands also, and there may be some improvement. And besides that, we have given antifungal antibiotics. So at the site, there may be second infection beside the tuberculosis with the fungus, with the pathogenic organisms also. The child was showing that improvement. But in the background, there may not be drug-resistant TB. Whether what are the results of that second bronchoscopy, granulation tissue removed, and NAT results and the culture results?
So, sir, the MGIT were collected later on. They were all no growth. So we did not have any evidence of drug resistance in this child. The CB0 which we had grown MTB, rifampicin resistance not detected, and MGITs were negative.
That was at the early stage, na? Second time.
Second scopy also. Both the scopies, BAL and MGITs are sent. So MGITs were no growth, and in one BAL we had rifampicin resistance not detected.
So one question was raised that what about doing these the vocal femmeters in case of the child, and that to a young child or 2 to 6 months of age, that in such a scenario, the child will not be cooperative to say 1, 2, 3. So you can do the vocal stemmeters while the child is crying, or you tap over the trachea and then to listen to the vibrations and compare.
So that is
Besides
what,
that,
yes, sir.
the thorax is very small. So you have rightly said that you may have the low presentations, or even the fingers can be used for the, say, localizing the signs. That's there.
So absolutely correct, sir. What I would add is that yes, we do not, with the child infants, whenever you start examining, they will cry, and that's what you use for vocal fremetus, and that is it. And I would say the utility of these tests should not be undermined. A history and an examination is a no-cost kind of an investigation, bedside, immediately available. Instead of waiting for big results and big investigation, these things should be tried wherever possible.
Okay. So still we should say be examining the mother again for any evidence of the reactivation or the reduction of TB. Please try to say catch hold of that mother also.
Yes, sir. So the whole of the family was, the symptom screening was done, the x-rays were done. And in one of the sibling, as they have shown, we started prophylactic INH, and the rest we did not find any evidence.
Agreed. The child was given the TPT, but what about the mother?
So mother was also well. X-ray was also done in the mother, which was normal as of now.
Okay. Thank you.
And also the family chest X-rays were normal. Dr. Kamal?
Yes, ma'am.
For others in the family, the chest X-rays were normal.
So we had the mother, the father, and her sibling.
Okay.
That is what was available with us.
So it was a nuclear family.
Yes.
Okay. Because
not nuclear, they could not bring rest of the people with them. They were not. They could not bring rest of the relatives to us. So it was advised.
One question, Dr. Sangeeta, please. So you have given that there is a 10-point scale, the symptom scale. So in that tachypnea is 1, but that is given very low score, 2 points only. Do you think that that is appropriate, or should we be giving in a child the higher scale once we are suspecting TB?
So the 10 symptom screening what has been adopted under the program, it has fever, cough, chest pain, then hemopsis goes low down, night sweats go low down, we have the respiratory rate, reduced playfulness, all those symptoms, then any swelling in the neck. All these symptoms, they are as 10 symptom screening in accordance with what you have for adults. The only juggle is that we have added the respiratory rate, and the night sweats have gone down. For adults, the night sweats, chest pain, etc., they are a bit higher up because the small child will not be able to tell about the chest pain, and night sweats are not frequent in children. So a bit of juggling has been done, but they were the most appropriate. And even WHO has commented that NTP has adopted these 10 symptom screening, and these symptoms are better than the 4 symptom screening adopted by the HIV programs. So that is regarding
the WHO symptom scoring. The tachypnea and the tachycardia is given just 2 score. Even fever is given 10. The lymphadenopathy 5. And I don't think that is appropriate. Tachypnea, tachycardia, even low score, low weightage.
Given any score, these are just symptom screening for the periphery. So that whenever there is a health worker who goes to the periphery, because the problem, as was highlighted even by the IAP president, that is, we are missing cases. So this is for the health workers. सिर्फ उनको टिक मारनी है कि भी फीवर है, more than 2 weeks duration, cough है. On those, they are just tick based. We have not given them any score. And it is written if the child has any 2 or more, then the child needs to be referred for ruling out of tuberculosis. So because we are missing out on cases in the periphery, so that was the reason NTP went ahead with this 10 symptoms. We are not given any particular score.
So in case of the contact of the TB, once we are giving TPT, then we have to rule out the active TB. Okay. So in that scenario, whether we should be going for the upfront CBNet and the upfront as is done for the cases, otherwise.
Understand your question, sir. What are you trying to? I mean, you're advocating it for adults, or you're telling us for
children. The child is symptomatic, then upfront XA and CBNet should be done.
That is done under the program. Initially, the symptoms were that fever, cough, loss of weight, loss of appetite, and history of contact. Now, those 4 symptoms, they have been increased to 10. And whenever there are 2 or more, such a child goes to the higher facility where the chest X-ray is available. And if the chest X-rays has some findings, then only we go ahead with the MAT, depending upon the respiratory specimen which is available. For an older child, best is sputum. A child who is giving saliva, we encourage for sputum induction, or even explain to the child what exactly needs to be done. That is, take a deep breath and then a strong cough. And for small children, we are still
in case of a child with 5 to 7 years, 7 months of the age, you may not have to.
Gastric aspirate. Gastric aspirate.
Gastric aspirate.
Yeah. Now, under the program, we are in the process of adopting stool.
Yes.
But it's not still adopted. Now, stool will be as an add-on sample. It will not be on its own, but an add-on to the respiratory sample.
Okay. In case of the respiratory TB also, and if there are symptoms suggestive of the GIT involvement also, the stool can be a non-invasive sample.
Yeah.
Okay. Thank you.
Yes, sir. Yes.
Thank you. Thank you.
So,
I think Dr. Soumya or Dr. Shilpi, you can please continue.
Dr. Shilpi, please.
So may I start?
Yes.
As Dr. Soumya has discussed the possibility of persistent respiratory distress in a child receiving ATT, in whom constitutional symptoms have already resolved and inflammatory markers has already come back to the baseline. So it can be, we have to look for the correct regimen and the dose compliance. We can look for superadded infection. We can look for any alternative diagnosis. It could be paradoxical reaction also. And we can also consider the possibility for multi-drug resistant TB. So when we are going to suspect the obstruction due to TB, if there is any recurrent or focal wheeze, especially unilateral, if there is persistent or biphasic stridor, if there is reduced air entry on one side, if there is persistent or progressive cough not responding to therapy, post-obstructive pneumonia, and despite resolution of constitutional symptoms, respiratory distress continues, as it was in our case. So mechanical obstruction causes, it can be extrinsic, intrinsic, and bronchial valve involvement. Extrinsic mechanism, it is more common in the children because they have the compliant airways. That is the tuberculous lymph node, it gets enlarges, it undergoes caseous necrosis, it compresses the adjacent bronchus externally, and the common site, right main bronchus, right middle lobe bronchus, and the left main bronchus, leading to epistaxis. Endobronchial TB, here the bronchial mucosa itself is getting infected. It is forming the granulation tissue, and the caseous debris, it is obstructing the lumen. It can be polypoidal or fibrostenotic lesions, and fibrostenosis causes long-lasting mechanical narrowing. Bronchial valve involvement, as TB is a chronic disease, it will cause inflammation, fibrosis, leading to bronchial stenosis. This narrows the lumen, and it can cause stricture, air trapping, and bronchiectasis. The treatment, the primary treatment is antitubercular therapy with corticosteroids, as it was given in our case also, particularly when the airway compression is caused by the enlarged lymph node, which is the common mechanism in children due to the compliant airways. Despite medical therapy, many patients still require bronchoscopic procedures. They can undergo dilation, stent insertion, or clearance of the obstructive caseous material by cryotherapy. In our case, cryotherapy was successfully employed to remove the granulation tissue. In more severe or irreversible obstruction, surgical options including lobectomy can also be needed. These are the other two case reports, Villarreal et al. And Gossard et al. There also the airway lumen was blocked by the caseous necrosis in endobronchial TB, which was successfully removed after cryotherapy, and the obstruction was relieved. So the take-home message is a multidisciplinary and holistic approach is essential whenever the respiratory complaints, they are not parallel with the improvement in the constitutional symptoms and the inflammatory markers as it was in our case. It should prompt evaluation beyond the usual causes of treatment failure that has already been discussed, despite the child receiving ATT therapy and if the child is not showing improvement in the respiratory symptoms. And we have to involve the pediatric pulmonology team so that they can proceed with the timely bronchoscopic evaluation and get to the accurate diagnosis. Persistent symptoms warrant the search for the reversible airway pathology as it was done in our case. Thank you.
So we have kept that session short because we had a lot of discussion otherwise also.
So one comment I can make, that in case of this on radiology, there was bilateral hyperinflation. Okay. So on the right side, the hyperinflation was because of the disease on the right side and destruction of the other lobes, or there was some check well mechanism which was causing the hyperinflation on the right side.
So, sir, in this particular chest X-ray, there was bilateral hyperinflation. It was not localized to one particular part. Diaphragms on both the sides was.
Understood. That's so because of the right lung involvement. And but because the other lobes on the right side, because of the compensation or because of the check valve mechanism, so both can be there.
The child, sir, because the child came with us with the acute short history of coryza and he had wheeze also, we believe that it was a viral bronchiolitis or pneumonia kind of picture which was causing that bilateral hyperinflation and not TB per se, which over time improved also. So the acute picture was complicated by a superadded viral pneumonia where this hyperinflation and wheeze is known bilateral.
So one of the cause for the deterioration can be check well mechanism. The lung is inflating, but the air is not coming out. So that should also be kept in such like scenario. Okay.
Yes, sir.
Any other questions? Any other comment? You want to ask something? Okay.
So today's case is a 7-month-old child. The child is having fever for last 1 month, cough from last 2 weeks, fast breathing and loose stools. The child was previously also admitted due to loose stools for 7 days. The contact history with the mother is also present. Mother had taken the DSTB treatment 2 years back. And the history of bottle feeding is also present. On the clinical examination, child is malnourished. Chest retraction was present, nasal flaring was present on the time, and fast breathing is present. Child is having saturation at 94% at the room air. Child is having pallor also. In the radiological investigation, child on the chest X-ray, child is having right upper and right middle lobe consolidation and collapse. On the CT examination, child has mediastinal necrosis lymph node also. The bronchoscopy was done on the bowel sample. The child was found MTB detected and drip sensitive TB. ATT was started with the steroid, but the child is persistently required the oxygen support and child is on HFNC. So the repeat bronchoscopy was planned and on the repeat bronchoscopy, the granulomatous tissue was present there, which was removed by the cryo biopsy. After that, child was improved by the ATT and respiratory distress was also improved, and later child was also gaining weight and child was discharged successfully.
Thank you, Dr. Alok. So there are 4 messages that I would like to tell the audience that we got from this case presentation. So the first was about tubercular chemoprophylaxis. Though the child was 7 months of age and the mother had received ATT, had the child been slightly older or had the child been born when the mother received ATT, the child should have been investigated at that point of time and was a candidate for TB chemoprophylaxis. The team in this case has done contact survey, and the eligible candidates were started on chemoprophylaxis. So this is one important facet of TB management which is often overlooked. So when we are managing our patients, we should be careful for contact survey and identify individuals who are eligible for TB chemoprophylaxis. The next important message we take from today's discussion is proving what microbiological confirmation. As in this case, the initial GAs were negative for TB for Mycobacterium tuberculosis. So an attempt was made by the team to look for microbiological confirmation by doing a bronchoscopy and taking a bronchoalveolar lavage. This facility may not be available everywhere, so all attempts should be made. The easiest available sample may be a peripheral lymph node. So do not overlook a good clinical examination. You might find a peripheral lymph node which may be subjected to FNAC, and you might get a microbiological confirmation from a peripheral site itself. Other important message from this discussion is usage of steroids in tuberculosis. As per NTEP, steroids are indicated in tubercular meningitis, miliary TB whenever there is alveolar arterial gradient, and in case of endobronchial TB, as we have seen in this case, and also when there are massive pleural effusions. And the next,
I'd like to edit you over here. Under the NTP, it is for obviously, as you said, for TBM and tubercular pericarditis. For miliary tuberculosis, we give steroids only if there is hypoxia. The arterial oxygen levels, they are low. Other conditions, they are all subjective. For pleural effusion, if it is massive or bilateral and it is causing, respiratory distress, or SpO2 is low. There are only two indications. That is, one is CNS TB, not TBM, CNS TB, and second is tubercular pericarditis. And regarding the contact survey, I would like to add over here, Dr. Kamal. I would request your team, if they can get in touch with the mother and offer because their details, the mother's details, would be there with the program. So the program's responsibility to do the reverse contact tracing. You have done your job, you have done the chest x-rays for whoever reported to you, but the program's responsibility still remains. If you pass on those details, the program will do the reverse contact tracing for the whole family, because it's not possible for the family to come over.
Absolutely.
And the fourth and the last point that I would like to make is whenever your patient is not responding, when you have ensured that the dosage and the compliance is good, then always think of alternative reasons. MDR may be one of the reasons, but not always the only reason. So there may be patients who may not be responding because of paradoxical reactions, as it has been discussed. It may be an iris or it may be a mechanical obstruction, as we saw in this case. So these are the four important messages that I wanted to highlight from today's case.
And the common things first, rule out, even treat comorbidities as happened in this case. There was SAM, then other comorbidity for children which you have to look at. Not in this case, but otherwise I'm telling diabetes, HIV, and also, things happened in this case takes us to the further workup, because monitoring is very important.
Any more questions? I would also request the audience to please take up the post-test questionnaire before we log out. Any other questions? If there are no more questions, I would like to invite Dr. Ashok Bhardwaj, Chairman of the National Task Force, for his closing remarks.
Thank you, madam. Thank you. So I could not listen the whole case because I was in the meeting. So I promised Sangeeta that I will come for the vote of thanks. So I thank everybody for this beautiful. I just missed Ashwini Sood intervention. He was silent today. I don't know why. So thank you everybody. Thank you for joining. But madam, I will like to say that in spite of intervention from IAP, the so both the president IAP, she is requesting time and again. So we must improve this attendance
Yes.
somehow.
Yes.
So I'll request everybody who is present here that please send link to everyone you know so that they can join, because many people do not get this link to join, do not get the information. So thank you very much, Sangeeta. I will be attached to this for all time together. Thank you very much. Thank you.
Thank you, sir. You have always been there. You told me that you are busy today, but and thanks for sparing your valuable time. And I would personally thank Dr.
Thank
Neelam
you.
Mohan,
Thank you. Thank you.
and Dr. Our President elect Dr. Singavalu, then DDG TV Madam. Dr. Sanjay Mattu is busy and an outstation visit, so he could not join. And Dr.
Yeah,
Ashok
I heard
Bhagan
Neelam Mohan. I heard
joined.
everything.
And
Yeah,
Dr.
thank you. It was brilliant. I was listening. It was pretty. The bronchoscopy images and all were very interesting. I was seeing carefully. Was it endo or broncho? It turned out to be broncho. But the last few things, there's almost so much to do. I think ये जो आप case series लेते हैं, you compile. This is your 25th or what?
25th. 25th. So we are coming out with
give me the case series of 25 and I can sort of make a PDF version of it. I mean, you all, not me, you all give it and I'll disseminate the 25 series as a PDF. So do that to me.
So,
the right and left hand can do it for
the
me.
Neelam, Indian Journal of Tuberculosis has offered us that they would love to publish these cases as
Very
in.
good. So उसमें डाल दो, once that comes, I can share
Yeah,
that with
yeah,
you.
yeah, yeah. Yeah. So we are in the process of compiling the cases, and so that would be a dedicated pediatric issue. And I'll request you and Dr. Singavalu to, I'll request you personally when that we are near journal to write a foreword for that. So.
Okay, best wishes. Thank you so much.
Thank you.
Have a good day.
Thank you.
So with this, we come to the end of our 25th Pediatric TB Eco Clinic, which had a successful and a fruitful discussion. I would like to thank everybody who joined today, and special thanks to Dr. Kamal and his team for the case presentation. I will still request the audience to please attempt the post-test questionnaire. We'll be keeping the link live for some time. Thank you very much, and see you next month with another important and interesting case discussion. See you. Goodbye.